Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community. Episode 16 includes 4 segments, starting with skin cancer prevention from the inside. When should you recommend nicotinamide? Followed by JAK inhibitors versus TNF inhibitors, comparative safety in immune-mediated inflammatory diseases. Then split dose methotrexate, how to squeeze more efficacy out of the same number of milligrams. And finally, systemic steroids and eczema. Is there a limit? It's fun stuff as always, so let's get started. Should we be writing nicotinamide prescriptions for every skin cancer patient? In a retrospective cohort study of over 33,000 patients published 17 September 2025 in JAMA Dermatology, nicotinamide chemoprophylaxis initiated after the first skin cancer decreased the risk of subsequent skin cancer by 54%. What else cuts skin cancer risk by more than half? Nothing, except maybe a lifelong cave-dwelling nocturnal existence. Not even sunscreen, as daily SPF clocks in at about 40 to 50% reduction. So if you're recommending sunscreen to your skin cancer patients, it makes sense to recommend nicotinamide too. However, early intervention is key, as the risk reduction declined with each additional skin cancer preceding nicotinamide initiation. After 4 skin cancers, there was no longer a reduction in the risk of basal cell carcinoma. Squamous cell carcinoma risk reduction dwindled with each additional skin cancer too, but continued to improve patients' odds even after 8 preceding skin cancers. That makes sense, as SCCs had the greatest risk reduction to begin with. Our highest risk population, solid organ transplant recipients, benefited too as long as nicotinamide was initiated after the first or second cutaneous malignancy. Better late than never though, as the overall pooled risk reduction was 14%, which was statistically significant. So how does nicotinamide lower skin cancer risk? Evidence that it reduces UV-mediated cutaneous immunosuppression dates back to 2008, and in 2014 we learned that it supports UV-induced DNA damage repair too. Since then, there's been mostly positive but admittedly mixed data regarding actinic keratosis and skin cancer prevention, especially in the immunosuppressed transplant population. Thanks to the study's authors for mining a large Veteran Affairs data set to confirm the protective role of nicotinamide in dermatology. Since it's a form of vitamin B3, also known as niacinamide, the intervention is widely available and costs as little as 4 cents a dose online. For the ballers, Ferndale Healthcare's HelioCare Advanced Supplement pairs nicotinamide with Polypodium leucotomus extract for extra protection. #not sponsored. The study dose was 500 milligrams BID, which is well tolerated as long as patients take the amide form, i.e. not niacin, which is infamous for causing unpleasant facial flushing. So the answer is yes, nicotinamide prescriptions for all your skin cancer patients. But you're already working sunscreen recommendations into every skin exam. How are you going to squeeze a nicotinamide discussion into the appointment too? Well, do what Dr. Sarah Aaron does. She wrote an editorial on the study in the same issue, and she suggested providing nicotinamide counseling during the excision. Next, are you more comfortable prescribing Humira than Rinvoq? Well, you're not alone. Humira has its imperfections, including 2 boxed warnings for serious infections and malignancies, but like family, we look past them. After all, TNF inhibitors and dermatology clinicians go back a long way. But we look sideways at JAK inhibitors as if they were in-laws at the family party. To determine whether our standoffish behavior is warranted, a systematic review and meta-analysis of 42 studies, including more than 813,000 patients with immune-mediated inflammatory diseases, including psoriasis, rheumatoid arthritis, and inflammatory bowel disease, published 10 September 2025 in JAMA Network Open, compared the safety of TNF inhibitors, including adalimumab, and etanercept, marketed in the U.S. as Humira and Enbrel respectively, to JAK inhibitors, including baricitinib, tofacitinib, and upadacitinib, marketed in the U.S. as Olumiant, Xeljanz, and Rinvoq respectively. And what did they find? No meaningful differences in the risk of serious infections, malignant neoplasms, or major cardiovascular events. There was a slightly higher risk of venous thromboembolism associated with JAK inhibitor use, but the incidence rate remained low at 0.57 versus 0.52 per 100 patient years. Interestingly, the increased VTE risk was seen in the rheumatoid arthritis subgroup, not in the inflammatory bowel disease patients. Data was not available for subgroup analysis in cutaneous disease. For those that reserve JAKs for young, otherwise healthy patients, the median age of the JAK inhibitor patients in this review was 56 years, which was older than the 52-year median age of the TNF patients. And patients with obesity, diabetes, hypertension, hyperlipidemia, and prior coronary artery disease were included. Thanks to the authors for putting the relative safety of JAK inhibitors into perspective. If you haven't yet welcomed JAK inhibitors into the family, it might be time to reach out and give them a hug. Next up, an easy methotrexate hack. If your patient takes more than 15 milligrams of methotrexate weekly, have them split it into a morning and evening dose. As oral doses go up, intestinal absorption goes down because the transport mechanism gets saturated. Split the dose and problem solved. But while the pharmacokinetics support improved bioavailability of split-dose methotrexate, evidence of improved efficacy has been lacking. So researchers in India pitted same-day split dosing against single dosing in a randomized controlled trial of 253 patients with active rheumatoid arthritis. Their results, published 29 August 2025 in Clinical Rheumatology, showed that in the split dose group at 16 weeks, significantly more patients achieved a good response, over 12% more, and fewer patients required a second DMARD, almost 20% less, but numerically more patients experienced transaminitis. If bioavailability increases, it makes sense that the adverse effects will too, so no surprises there. At 24 weeks, the split dose groups lead narrowed to 6.5% more patients achieving a good response, but the difference was no longer statistically significant. The corresponding author admitted that allowing inadequate responders to add leflunomide or sulfasalazine at week 16 may have muddied the 24-week data. So more studies are needed to determine whether there is a long-term efficacy advantage to split dose regimens. If there is, an additional advantage may be lower costs for patients who have to pay for fewer tablets. If there isn't, the faster onset alone may make a meaningful difference in terms of reducing patient suffering and improving adherence, especially now that methotrexate has to compete against speedy biologics and novel small molecules. And in the US, where anything but 2.5 milligram tablets can be difficult or expensive to obtain, split dosing means fewer pills per swallow. The max psoriasis dose is 25 milligrams, for example, so if my math is correct, that's 10 pills at once with single-dose regimens, and nobody relishes that. But divide that BID and it becomes doable. Why do we dose methotrexate weekly anyway? Especially since the half-life for the doses we use in dermatology is only 3 to 10 hours. It's because once the molecule gets inside the cell, it's converted into long-acting metabolites that last for weeks. So weekly dosing maintains a steady-state anti-inflammatory effect while avoiding toxicity. These results have not been replicated in Derm, but transferability to cutaneous disease is more than plausible. So why not split it and quit it for the week? If nothing else, your patients will enjoy faster relief with more manageable doses. Thanks to the authors of this study for asking whether the science supports our practice. And finally, the news that a single Kenalog shot or prednisone taper qualifies your atopic dermatitis patient for a biologic or JAK inhibitor. That's the assertion in a position paper published 6 September 2025 in the Journal of Investigative Dermatology by Joshua Burstein, Christopher Bunick, Ruth Ann Vlugels, April Armstrong, Alexander Golant, Todd Schlesinger, Bruce Strober, Eigen James Song, Linda Stein Gold, and Mark Lebwell. Talk about a powerhouse Delphi expert consensus panel. But why publish a position paper when the AD guidelines already recommend against systemic corticosteroids? Well, because almost 1 in 5 AD patients is treated with systemic corticosteroids, and approximately 1/3 of those for over 30 days. Even short courses, median 6 days, at low doses, less than 20 milligrams per day, have been associated with significantly increased rates of sepsis, venous thromboembolism, and fracture. And the 2 to 3 week courses of moderate dose prednisone commonly used in dermatology have been linked to avascular necrosis of the hip. By the way, the body produces the equivalent of 4 to 6 milligrams of prednisone per day, so anything above that can lead to hypothalamic pituitary adrenal axis suppression within 3 weeks. The range of potential systemic corticosteroid toxicities is broad, from gastritis to weight gain to hypertension, hyperlipidemia, diabetes, osteoporosis, Cushing syndrome, and even behavioral changes. And some adverse effects, like cataracts, are irreversible. Despite the strong recommendation for oral JAK inhibitors like abrocitinib and upadacitinib in the AAD guidelines, many prednisone prescribers worry about their cardiovascular risks, perhaps without realizing that the longer patients are exposed to systemic corticosteroids, the more their risk of MACE and VTE goes up. The Derm stars note that in contrast to JAK inhibitors and biologic agents, systemic corticosteroids have not undergone rigorous, indication-specific randomized control trials. In addition to a robust body of data supporting their relative safety, JAKs may pose less risk of rebound flares, which occur in up to 81% of patients after taking prednisolone. That, coupled with their rapid onset, may make JAKs a fitting replacement for systemic corticosteroids in scenarios requiring prompt disease control. The panel's call for change extends beyond clinicians to payers who often require conventional systemic immunosuppressants such as cyclosporine, methotrexate, azathioprine, and mycophenolate mofetil, despite their less favorable risk and efficacy profiles compared to advanced corticosteroid-sparing systemic agents. So let's evolve and elevate our eczema care by moving away from serial systemic corticosteroids to novel targeted systemics. And that wraps up episode 16. Derm Drop is written and hosted by me, David Sider, with production, distribution, and promotion by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Seiter, spelled Seiter. Questions and comments can be sent to us at dermdrop@gmail.com. And if you had a good time and learned something useful, give us some love with a thumbs up, 5 stars, a comment, or review, and be sure to tell your colleagues. Thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.